Okay, it says continue. Good.
Good morning. Hi, everyone. Welcome. My name is Amer Johri, and it is my pleasure to introduce the inaugural JASE Podcast Summer 2021 series. And for this inaugural episode, it's my great pleasure to have Sharon Mulvagh here presenting with us. As you know, this is a series that we do that kind of whets the appetite for the reader and introduces them to the paper that is recently being published in the Journal of the American Society of Echo. We're not providing a full dissection of the paper because we really want you to download it and read it, but we want to give you a little bit of introduction. So again, as I mentioned, it's my pleasure to have Dr. Mulvagh here. Dr. Mulvagh, how are you doing this morning?
Great, Dr. Johri. How are you doing?
I'm doing well. Tell us what's new in your end of the world.
Well, it's a beautiful, fantastic June summer day here. I just got back from about 10K run, and I am just absolutely in a chill mood, just enjoying being with you there in the lake, it looks like as well. I'd love to
Yes,
go for a swim.
it's a lovely morning. I'm in front of Lake Ontario, and I've heard you have a beautiful vineyard you like to take care of.
Yeah, actually, I'm at our vineyard cottage right now, and we do have 32 acres here, and we grow a variety of different grapes. We have several vinifera, Chardonnay, Riesling, and Pinot Noir. And as well, we have, like 7 or 8 different cold hardy hybrids as well. So, yeah, we're quite busy with a lot of activities there. And my husband manages most of the vineyard, but I'm actually, as I shared with you, doing an online winemaking course at UC Davis as well. So there's lots happening. It's
That's
really
amazing.
a yeah,
Yeah,
it's really a wonderful, and the Annapolis Valley is gorgeous here in Nova Scotia. I feel very, very fortunate, and I'm so glad to be
sounds
here.
wonderful. Yes.
Yeah, and
And
to join you in Ontario this morning
yeah,
too.
yes, exactly. And once again, I know it's not new news, but congratulations as the incoming president of the Canadian Society of Echocardiography. We don't know how you do all of this, and it's quite amazing. It's you're such a valued member of the echo community. So thank you for all the work you do.
Well, thank you very much, Amer. And of course, the ASC Scientific Sessions 2021 is just around the corner in a couple of
Exactly.
weekends.
Yes, very
Yeah, so
exciting.
that's, and then before you know it, it'll be 2022. And I am the chair for the 2022 Scientific Sessions for ASC. And Cross Fingers will all be together in Seattle. And this will
That's in
hopefully
Seattle,
be,
Washington, isn't it? Okay.
yeah, a fantastic
That one.
reunion. That's what we're looking forward to. It's great.
Wonderful. Yes. And so the paper that we're going to be talking about today was in fact related to some of the work that you did at Mayo. So can you tell us a little bit about your background there and your work back before you moved to Canada?
Oh, thank you for that opportunity, Amer. Yes, actually, I had a 26-year career at Mayo, a wonderful opportunity there. I worked in the echo lab, focus on stress echo, contrast echo, well, comprehensive echo, but I did my investigative work primarily in contrast echo. And as you know, I contributed to the guidelines documents and a lot of work in that direction, mostly all through ASE, and that was a wonderful opportunity. The other aspect that I had the pleasure of performing and sharing in was being the director of the Women's Heart Health Clinic there. And so my interests are really focused on women's cardiovascular disease, as well as echocardiography and contrast, and as well point of care ultrasound. So when I transitioned back to Canada in 2016, those are the 3 things that I really do now, and I enjoy it greatly. So plus, the other recreational and outdoor activities that we've shared earlier. It's really a full time, and yeah,
Yes,
I'm
that's
very
wonderful.
appreciative.
Yes. And certainly the paper we're going to talk about today has been the source of inspiration for my trial. That is a North American trial looking at the use of carotid ultrasound and stress echocardiography. And we were inspired by your work, informed the grant, and we're taking it into a multi-center approach. So this is the idea where we're looking at enhancing the stress echocardiogram with the addition of carotid ultrasound. And specifically in this particular case, looking at neovascularization of carotid arterial plaque, which could be an indicator of advanced or advanced lesions or a vulnerable milieu within a patient that is at risk of cardiovascular disease. So just a comment or two on that, and then we'll get into your paper.
Yes, and it's been really amazing to me how so many of our interests actually are intersected, and so we've had the opportunity to collaborate since I've been back in Canada, and that's great. So, gosh, it was probably in around 2012 or so when one of our research fellows, Renjing Huang, came to us from China, Tongji University. And Renjing had a very focused idea that she really wanted to look at carotid plaque and contrast and be able to assess for vascular vulnerability. And so we worked together on developing a protocol. And this is a prognostic study that I really have to give the majority of the credit does go to Renjing. She just drove this protocol and did a wonderful job of it. So the concept was that patients that would come for stress echocardiography, we would be able to look also at their carotid arteries, and if they had plaques, as evidenced on ultrasound, then it was our interest, given the work that Steve Feinstein had done in particular, to determine if there was intraplaque neovascularization, as you mentioned. This it's almost like an angiogenic, tumorigenic response, like angiogenesis stimulates. And when there's an atherosclerotic plaque, then it is fed by these neovascularized vessels. So we looked at utilizing contrast in particular to be able to demonstrate this vascularity in patients that were at relatively high risk for cardiovascular events. And the result of that was a prospective study, which we recruited over 200 patients. It was interesting that most of the patients actually are men, because they were a higher risk group of patients coming for stress echoes. And that when we looked, it's shocking to actually see that most patients that are coming for an assessment of their cardiovascular disease, their cardiac symptoms, also do have carotid vascular disease. I think it was about 86% of the patients had carotid plaques. That 15% or so we could not study with our contrast interplaque neovascularization assessment because they didn't have carotid plaques. But that just tells you that in this, this was a higher risk population, that atherosclerosis is a diffuse systemic vascular disease, as we know. So we looked at these patients, and we found that indeed it is a very specific marker for cardiovascular outcomes if there is the presence of intravascular neovascularization in these plaques, more so than if it's just a plain plaque. Other groups, Roxy Senior's group, your group, has looking at plaques in the carotids as a way of being able to stratify higher risk patients that are presenting with cardiac disease, and have found it to be an indicator. But even more, if the plaque is indicated to be vulnerable or active, with active vascularity within it, as demonstrated by microbubbles presence in the plaque, then this is an extra marker, it seems. So that was the gist of the study, and we can talk about some more details if you like.
Sure, yes. So one of the things that I'm aware of is that we have just listeners who may not be seeing the actual figures. And so if there's a figure or two you'd like to describe and show as well during the audio portion, you can show it to us now. And I encourage our readers to also download the paper. Again, we at this stage are trying to introduce Dr. Mulvagh's work to the audience.
Great. So I had as the cue to share my screen. So here we go. Let's see. Can you see my screen
Yep,
okay
that
there,
sounds
Amer?
great. Yes.
Okay. All right. So as I mentioned, this was a prospective study. The patients that were coming to the stress echo lab for either exercise or dobutamine stress test, we offered them if they wanted to come into the study, and we explored whether or not they had plaques in their carotid arteries at baseline. And of the 216 patients that were recruited prospectively, 185 did have plaques, and they consented to having a contrast study. Our contrast agent that we used was Optizon in this particular study, and it was given intravenously in the routine way that we would do it for cardiac imaging, with a small bolus dose followed by a saline flush. And in a small subset of patients, we also asked them if they would consent to an MRI study, because we had the opportunity to also compare the MR features of the carotid plaques with the intraplaque neovascularization. So that was about 27 patients that went on for a carotid MRI study as well. And then we followed up the patients for 2 years, and this was through our electronic medical records and telephone calls. And this is just for those of you that are visually able to see the images, or please go to the paper and you'll see them. And we do have some videos as well that can supplementary show the concept of the contrast enhanced ultrasound showing the intraplaque neovascularization. And you'll see here, these are these tiny microbubbles that actually appear in the carotid plaque. And they can be either diffusely through the plaque, as seen in this figure A. In figure B, they're also seen relatively diffusely, or they can be localized to the shoulders, the edges of the plaques. And there's some work that would suggest that when there is more vascularity at the shoulders or edges of the plaques, that this may be an increased marker for vulnerability. So that's why we sought to look at this. Now, one of the limitations of our study was that these are 2D images. They're not 3D images of the carotid vascularity. And also that unfortunately, we used there's really no good quantitative assessment of the microbubble presence within the plaques, so we used a qualitative assessment. The subset that underwent MRI, as shown here, had special imaging to be able to evaluate the lipid-rich necrotic core area, as well as areas of intraplaque hemorrhage. And then the other component of a plaque is called a loose matrix. And there's been a lot of work, and actually Kevin DeMarco, who's one of the leaders in this area in the MRI imaging, was one of our co-authors, and there's been a very well-established body of work that has looked at what makes plaques more vulnerable on MRI and what the markers are. And certainly intraplaque hemorrhage and the lipid-rich necrotic core seem to be the two features of a plaque that correlate with more vulnerability, i.e. more likelihood that it will rupture and cause a clinical event down the road. And these are some of the 3D reconstructed images showing the lipid-rich necrotic core and the hemorrhage in plaques. So we had this information to compare with the ultrasound information of the contrast imaging in the plaques. And this figure actually, or table shows the baseline characteristics of our patients, as I mentioned, and stratified according to whether or not they had intraplaque neovascularization or not. And as I mentioned, most of the patients were actually men, and this was just who was coming for stress tests and who consented to go into the study. The clinical characteristics were kind of what we would usually expect in these patients. And the only thing that really was different was the fact that there were more men than women in the study. We put it as a threshold. The significance of a plaque was the carotid intima media thickness that was at least 2 millimeters. And we saw that there was a hint that if there was a more intense carotid intima media thickness or increased, then that went along with plaque intraplaque neovascularization as well. We also looked at statins in the patients, statin use, and the lipid profiles. And we found that those patients that had intraplaque neovascularization tended to have higher triglyceride levels as well as lower HDL levels. And they also tended to be on statins for a shorter duration of time for those that were on statins. So there seemed to be a marker that some of our lipid parameters, specifically triglycerides and low HDL, the things that we see clinically with metabolic syndrome, correlated with the more active, or the plaque intraplaque neovascularization that would seem to indicate a more vulnerable plaque. As well as those that had shorter statin duration, they did not. They showed more of a plaque vulnerability than those that were a longer duration of statins. We noted that the intraplaque neovascularization similarly seemed to correlate with on the MRI studies with a larger volume of lipid-rich necrotic core, as well as the presence of intraplaque hemorrhage. So again, looking in the same direction as plaque vulnerability, the intraplaque neovascularization by contrast was a marker. And then with respect to the outcome studies, we looked at stratifying the patients over time for cardiovascular events based upon the tests that we had done, the stress echo test and the contrast of the carotids and presence or not of intraplaque neovascularization, as well as the location of it, whether it was just present or absent, as well as if it was in the shoulder. Interestingly, we didn't. We had approximately 26 cardiovascular events over the 2 years, which was a little lower than we had anticipated for our power calculations. But that probably is the reason why we didn't actually see that the stress echo test stratified out patients. There was no significance in those that had normal versus abnormal stress echo testing in the prediction of cardiovascular events. Now, importantly too, in the stress echo, we did define an abnormal stress echo as those that had fixed defects, not just induction of ischemia. And about a third of the patients had fixed defects, i.e. scar at rest and stress, no change. And only about a third did have evidence of inducible wall motion abnormalities consistent with ischemia. So that might be why there was not as much of a differentiation by the stress echo. But given that, we found that intraplaque neovascularization could differentiate in the prediction of whether a cardiovascular event would occur. And as you see here in figure B, in those patients that had intraplaque neovascularization, which was present, they had a worse outcome than those that did not have it. And then if you looked at the shoulder location of the microbubbles,
and that's at 40 months of follow-up, isn't it, where you start seeing
where the curves separate more so. Exactly, good point, because you can't, looks like for the first year, maybe 10 months, there wasn't much separation, but it did separate out starting after that point, and quite dramatically so, even at 30 months. So yeah, and we did obviously have some drop off in patients at that point, but it is interesting that there was a separation, and there wasn't with stress echo, right?
Yes.
And then when we look at the location of the interplaque neovascularization, specifically the shoulder, it seemed to separate it even more significantly. And it was earlier too. You can see here, good point, that the separation it was occurring here between 5 and 10 months. So there certainly does seem to be an association of the presence of microbubbles within a plaque, particularly if it's at the shoulders, with making it more vulnerable to having cardiovascular events. Now, importantly, the events were not all strokes either. The majority were cardiac deaths. Was about 6, and cardiac or myocardial infarctions in about 9, and unstable angina in the balance, and only 3 had stroke or TIA. So it shows, again, systemic vulnerability as opposed to the focal issue with a vulnerability specific.
Those are two really good points. The first is that for some reason, bubbles within the shoulder seem to be higher risk than bubbles within the center portion of the plaque. And it's an interesting thing to think about the process. And then the other really interesting point you brought up is that you would expect stroke-related outcomes because you're looking at carotids, but in fact, it's cardiac outcomes that we're talking about in these patients.
Exactly. That's exactly. So it's a systemic issue here with vascular inflammation, which predisposes to cardiovascular events. It's not just strokes. There was a subset that we noted, of course, that there were significant flow-limiting carotid stenosis. It was a very small group, and those patients actually were treated clinically. Nobody knew, right? They just entered our study. They didn't necessarily have symptoms or anything. So it was uncovering that, and they were managed clinically. But it wasn't really in those patients that the events actually occurred. So it's more of a, just like we see in patients that have, coronary artery disease, and, we see a fixed stenosis, but it's not necessarily that is where going to be the culprit artery with the cardiovascular event down the road. It's probably in another vessel because there's plaque rupture. And again, it's a marker of the vulnerability. The plaque vulnerability is what we're looking to. So the bottom 2 graphs here show the combination of using stress echo, or the results with the stress echo and the carotid enhanced ultrasound imaging, the interplaque neovascularization detection. And you can see that there actually is an additive. If you have both abnormal stress echo and interplaque neovascularization present, then the outcomes were worse in those patients than those that had normal stress echo and no interplaque neovascularization, with intermediate outcomes with the combinations in between. So that I think was relatively helpful, and it was a more accentuated effect if, again, we looked at interplaque neovascularization on the shoulders. It separated out the groups even more. So that it does seem to be that it is the useful marker in that regard.
It's very fascinating.
Yeah, I mean, it's a small study, single center, but you've done work that's similar, more in an acute phase, like in early mortality, like within 30 days, and I think I've found similar things, right, Amer?
Yes, exactly. So we found that the presence of neovascularization predicted myocardial infarction and cardiovascular outcomes at 30 days. And it was a very small minority of patients that had stroke. So similar findings are being found by multiple groups now.
Yeah, exactly. So I think that this is just actually, this table shows that we did some Cox regression models with both univariate and multivariate analysis to be able to stratify out the impact of the interplaque neovascularization in total, and then in the shoulder, and then other characteristic findings. For example, the echolucency of plaques has nothing to do with contrast, but that have been previously recognized as an increased marker. And we found that actually in the multivariate analysis, it was only the intraplaque neovascularization strongest at the shoulders, but also overall that was associated with cardiovascular events significantly. So that led us, again, this shows that there was no other associations on the univariate analysis. That led us to do the Cox regression model sequentially to fit test and determine the incremental value of intraplaque neovascularization in the shoulder. And we found versus the intraplaque neovascularization in general, in the advantage over just having abnormal stress echo, history of coronary artery disease. And we found that the presence of the intraplaque neovascularization in the shoulder increased the likelihood of cardiovascular events beyond the stress echo findings alone, and history of CD. So it had the most significant impact. So I think that the conclusions from our study that, they're certainly not definitive, but they certainly are tantalizing in that this technique appears to provide a useful bedside portable non-invasive tool, allowing examination of carotid artery intraplaque neovascularization activity. So giving intravenous contrast agents, which we use every day for stress echo testing, and then just moving the transducer. We did use a dedicated, the GE Logic system, actually a dedicated linear vascular transducer with the carotid package of software that comes on that machine for our analysis. But having that opportunity in the stress echo lab to, if you're going to be looking, more than half of our patients generally have contrast to be able to improve their endocardial definition and wall motion assessment and enable, more accuracy in their stress echo testing, to then at the same time or in the same examination look also at the carotid for this intraplaque neovascularization activity as a vascular marker, a window into vascular health, and a marker of systemic vascular inflammation, and to improve our risk stratification, i.e. intensify therapy. Let's say even the stress echo is negative, but you find intraplaque neovascularization in the carotid. Well, that patient, you want to make sure that their lipids are optimal, that, we are managing their cardiovascular risk factors, their diabetes is under the best control if they're diabetic, their blood pressure is under the best control, they don't smoke anymore. All of those things to try to reduce their cardiovascular risk, because if we see intraplaque neovascularization on contrast-enhanced ultrasound, I think that the evidence is pointing in the direction that this is a marker of vulnerability, and this patient is at increased risk. So we need to be extra diligent in managing that risk for them.
Wonderful. This is amazing work. Thank you so much for summarizing that for us. A couple of points I want to bring up. As you know, the American Society of Echo recently published the new guidelines for carotid ultrasound. And this work fits very nicely into those recommendations, where they talk about looking for plaque, and helping you to stratify patients as low, intermediate, or high risk. And then, in fact, if the patient has beyond plaque, if they have neovascularized plaque, to rethink whether they're even at a higher risk. And there's a very nice algorithm presented in those recommendations. So I would encourage our readers to take a look at those recommendations, which complement your work and have been informed by your group and other groups. The other point I want to bring up is just the logistics. So, it's a very good point that you bring up, that learning vascular ultrasound is not difficult for sonographers. They do much more advanced imaging, and quite a few of them have already learned vascular ultrasound during their training. And in fact, there are hybrid sonographers there, and there are hybrid labs. And this really goes to the idea that, we're probably underutilizing the power of vascular ultrasound and ultrasound in general. And in this era where we're trying to better define what we as cardiologists are bringing to the world of ultrasound, we shouldn't ignore tools that really help. And so in terms of the logistics, as you mentioned, you're already giving contrast quite often. And so you're giving a bit more contrast and now looking for additional information. Whereas the stress echo is providing functional information, you are complementing that with some wonderful anatomic information as well. So I really like this idea of a combination and further empowering stress echocardiography. I'd like you to comment in closing on how you have helped advance this work through a project funded by the Canadian Institute of Health Sciences Research, the CIHR, and this multi-center North American trial to further disseminate this concept of assessing neovascularization during stress echocardiography.
Yes, thanks for that opportunity as well, Amer. And I'd just like to make one brief comment, and that was just on the logistics. We actually did the carotid imaging before the patient came for their clinically indicated stress echo, and we never used more contrast because it was a bit of a draw for the patient actually to come into the study because they would get free contrast. In the US, you had to pay for the contrast, right? It's a different story. I mean, the patient will get billed for it. So that we always sent the vial, which there was always a contrast remaining because we never used that much. It doesn't take very much is the point, along with the patient for their clinically indicated stress echo portion, and that way we never used more than one vial of contrast. So it just, as I don't want people to think that this takes more contrast to do this, you can do this all within the same clinical.
Thank you for that clarification. That's really important, and
yeah.
that also distinguishes the prospective trial.
Yes, exactly. So that does, it makes it very like logistically straightforward. So the large prospective study that I have the good fortune of collaborating with you on, Amer, and you are the PI on this study, our CIRCE study. I always come up with these great acronyms. So the point is that we don't know when we have a negative stress echo, really, what is the patient's overall risk going forward. And I think that we see this happen quite significant, not infrequently, that the patient does come for a stress echo and then it's normal, but down the road there are events that occur. So it was our idea to be able to further stratify this population and really evaluate what their systemic vascular atherosclerotic and plaque vulnerability risk was. So we have, I think, 1,200 patients that we're going to study? 1,500 across Canada, and like 6 or 7 sites, and Steve Feinstein will be also a site in the US. So it's an international study, and we'll be conducting this over actually a 4 or 5 year period. So there'll be adequate follow-up for outcomes in these patients. And we will be looking specifically at those patients that have residual risk potentially that has not been uncovered by the stress echocardiogram. And I think that it will provide very useful results going forward. And quite frankly, I mean, it might be at some point that we just do vascular imaging and skip the stress echo, because we know that, obstructive coronary disease, like predictable exertional angina, that's one, it's a different animal than
A
really plaque vulnerability.
great topic for a debate, I've just realized.
I think so. Maybe we could propose something like that, Amer, coming up along the way. So how do we put these pieces together? What's the most logistical way, and what is the benefit going down the road? So I think, it's very valuable. Patients, in my experience, if you show them that they've got guck in their carotid artery, it's kind of a shocking experience. And if you see please go to the article and look at the supplementary videos as well, and you see and you've seen many of us present at meetings too, the actual appearance of the microbubbles within the plaque, it's almost kind of creepy that, this is really inflamed. That should not be there. This is, the intimal perfusion to an area that is should have nothing, because it's only there because of this malignant atherosclerotic process that's going on. So if you demonstrate that to a patient, I think that it perhaps has more impact too on how they manage their own risk, and in complying with medications and lifestyle. Always lifestyle is the primary approach to optimizing cardiovascular risk and prevention.
Wonderful. Thank you, Dr. Mulvagh, for summarizing all that work. Once again, to my readers, to the audience, I recommend that you go to the Journal of the American Society of Echocardiography in the June issue. The paper is now available. There's a wonderful editorial by Dr. Roxy Senior as well on this paper, so I encourage you to read both. And the other announcement that I just want to remind everyone is the upcoming ASC scientific sessions in a few weeks. That's going to be an exciting time. And finally, I just want to mention that please stay tuned. We're going to be doing a weekly series. And so every week we'll be picking an article from the Journal of American Society of Echocardiography and presenting a brief audio clip with some visual component, but you can just listen to it as well while you're gardening, while you're driving or on your run.
Running, biking. Yes, exactly. Just be aware of the traffic around you.
That's right. Very important. Yeah.
Hopefully you're on a nice quiet country road and you don't have to worry too much about that.
Yeah.
So you moved inside, Amer. I see you've got a different background now.
What happened was I needed a little bit more power. And so, we changed location, but
you got beamed up.
That's right. It's always fun to have a conversation about this really important work with you, and I really appreciate your time. And it's been wonderful to have you for our inaugural summer series.
Next time, I'll take you out to the vineyard with me. How's that?
Excellent. Let's do that.
All right. Take care.
Thanks, everyone.
Thanks, Amer.
Bye.
Bye.